Hrita Gogate, Comparative Study of Laser Retinopexy in MIVS with gas for rhegmatogenous retinal detachment.
Hello and good afternoon to all. I am Dr. Hrita and I am here to talk about comparative study of laser retinopexy in MIVS with C3F8 gas for rhegmatogenous RDs. Now, as we all know, vitrectomy has overtaken scleral buckling even in treating uncomplicated rhegmatogenous RDs. This is owing to the better instrumentation and the better viewing systems that exist today. Now, with vitrectomy, endolaser is the preferred mode of retinopexy, and this is either done 360 degrees, creating a similar aura, or localized to the break and other suspicious areas. The aim of our study was to compare 360 degree versus limited endolaser retinopexy in MIVS for rhegmatogenous retinal detachments. It was a retrospective comparative interventional study in which data of patients who underwent primary MIVS for RRDs from January 2014 to December 2016 was reviewed. The patients were divided in two groups, group 1 being 360 degree retinopexy and group 2 being localized retinopexy. The data collected included basic demographic data, the pre and the post-operative best corrected visual acuity, intraocular pressure, anatomic outcomes, and complications, if any. The surgery performed included core vitrectomy followed by PVD induction with triamcinolone acetonide in cases where there was no pre-existing PVD. This was followed by peripheral vitreous-based trimming done with dynamic scleral depression. We also used PFCL in few cases to stabilize the posterior pole. This was followed by retinal flattening by fluid air exchange, and then endolaser, which was either localized or 360 degrees. In the end, we injected 10% C3F8 as a tamponade. The outcomes studied were anatomic success rates, functional outcomes, and complications. Coming to the results, a total of 89 patients were reviewed, out of which 62 were in group 1 and 27 were in group 2. The age range extended from 16 years to 87 years, the mean being around 50s. The pre-operative visual acuity in group 1 was 1.769 log mar, and in group 2 was 1.859. Post-operatively, it improved significantly to 0.679 in group 1 and 0.674 in group 2. Coming to the anatomic success, in group 1, 56 out of the 62 eyes, that is 90.32% patients achieved anatomic success, and in group 2, 26 out of 27, that is 96.3% achieved anatomic success. Coming to the functional outcomes, in both the groups, we had a statistically significant improvement in the best corrected visual acuity individually. However, there was no intergroup significant difference that we found, wherein the p-value between the intergroup variation was more than 0.05. Coming to the complication, the most common complication we encountered was a temporary rise in IOP, which was controlled medically. The other complications encountered were cataract and subretinal fibrosis in one patient. The patients who had cataract underwent phacoemulsification with intraocular implantation. One patient had subretinal fibrosis, but it was left alone because it was not affecting the visual axis. Coming to the discussion, laser is the preferred modality of retinopexy today with vitrectomy. And although lesser than cryotherapy, excessive laser has also been implicated as a risk factor for future PVR. Thus, limited laser retinopexy could be useful, one, in reducing the operating time, and secondly, in also reducing complications like possibly an increased risk of PVR. Concluding, in our study, compared with localized laser retinopexy, 360 degree laser did not give any additional benefit with respect to anatomic and visual outcomes for our patients. However, it was a small sample size, it was a retrospective study, so we really need a long-term study, a long-term prospective study to validate our results further. The point I want to bring home is judicious use of laser is vital because it can be an important parameter for PVR later on. Thank you.
So, doctor, how did you choose which patients to go for limited and which ones? Because your numbers were like 3:1, almost 60 something and 20 something.
So it was.
How did you choose which patients would go for limited and which would go for this thing? One can, I mean, even when it was being done, it could either have been a surgeon bias,
Yes,
or
sir.
it could be the simpler cases went for the limited.
So basically, it was the surgeon's discretion at the operating table, and most commonly, like you said, the subtotal and the total RDs went for 360-degree lasers, and 2-quadrant or 3-quadrant RDs went for. That's why we have more number of patients in the 360-degree.
So to draw valid, conclusions, one would have to have the same kind of patients.
Yes,
there.
true, sir.
And was it a single surgeon or was it different? What is the experience of the surgeon? Single surgeon?
Two surgeons.
Two surgeons. Okay.
You said one of the advantages of having a limited laser is the extensive laser will give more of PVR. What is your follow-up?
So my minimum follow-up was 4 months, and the maximum we achieved in one patient was 9 months. It is still lesser, but we feel that it is still valid because the maximum chance of PVR is within the first 6 months.
And all these cases were successful. You didn't have a recurrence in any of these cases?
So one patient in group 2 and few patients in group 1. I had mentioned that.
Okay.
Yeah.
And all the oil cases you have excluded. Only gas cases you have taken.
Pardon, sir?
All the silicon oil cases you have excluded.
Yes.
Only
yes.
the gas cases.
Only
you have
gas
taken.
cases. Yes, sir.
And also you have compared the visual outcome secondary to the limited laser as well as the 360-degree laser.
Yes, ma'am.
Have you ever looked into, so what was the nature of detachment and what was the duration of detachment, what was the macular status and any other lens status and other things?
So lens status and macular status we have looked into, but the duration of detachment, as you said, we have not really analyzed that, and we have not done a subgroup analysis for the phakic status of the patient. Which
so the anatomical success is fine, but if you conclude with the visual outcome following the limited laser may not be directly effective to the
yes.
laser alone.
Yes, true, ma'am.
You are talking about green laser in all cases?
Pardon, sir?
You are using green laser in all cases, or is red laser also used?
Green laser, sir.